right. Good evening, everybody. On behalf of the American Neurogastroenterology and Motility Society, I'd like to welcome you to our clinical virtual symposium this evening entitled Guiding Practice, Translating IBS Societal Guidelines to Patient Care. I'm Greg Sayuk. I'm a professor of medicine and psychiatry in the Division of Gastroenterology at Washington University in St. Louis. And I'm a member of the ANMS Council, where I serve as treasurer and chair of the communications subcommittee. It's my privilege to serve as host and moderator for this evening's program. I'm joined by my friend and co-moderator for this webinar, Kavita Kongara. Dr. Kongara is a clinical chair of motility at United Digestive and Georgia Physician Executive Board member of Atlanta Gastroenterology Associates. She's also the director of their motility center and is serving as her second term at the American College of Gastroenterology in the Women's Committee, and is also co-chair of the Work and Life Balance Subcommittee. She has been recognized as a top doctor by her peers at the Atlanta magazine in 2024. Good evening, Kavita.
Good evening, Greg. Thank you for having me participate. Very excited to be here.
It's going to be a great program that we have lined up for everybody. So without further ado, let's get to our program. We have two talks planned for this evening. The first is entitled What's the Evidence for What We Do in IBS by Dr. Brian Lacy. And Dr. Andrea Shin's going to then follow with a discussion of the IBS guidelines and how they stand up in clinical practice. Our format for this evening's program will be a 20-minute presentation followed by a 20-minute question and answer. We encourage you during the talks to post your questions on the Q&A at the bottom of our Zoom. And we will then at the end have our distinguished discussants get to as many of these questions as possible. Please note that this program will be recorded and posted on YouTube for future reference as well. So with all of that, I would like then to introduce our first speaker, Dr. Brian Lacy. Dr. Lacy is currently professor of medicine and consultant at Mayo Clinic-Jacksonville. He previously worked at Dartmouth Hitchcock Medical Center, where he was the section chief of gastroenterology and hepatology, and professor of medicine at the Geisel School of Medicine at Dartmouth. Dr. Lacy's clinical and basic science interests include focus on disorders of gastrointestinal motility, with an emphasis on irritable bowel syndrome, dyspepsia, gastroparesis, constipation, achalasia, and intestinal pseudoobstruction. Dr. Lacy, you may recognize, was the first author of the 2021 ACG clinical guideline entitled Management of Irritable Bowel Syndrome. And many of you will also recognize Dr. Lacy as the former voice of the AJG author podcast, where he always brought in-depth discussion to his listeners, as well as an easy to understand review of cutting-edge topics in gastroenterology and hepatology. So with that, I'd like to welcome Dr. Lacy, and I very much look forward to his perspective on the evidence for what we do in the management of IBS. Dr. Lacy?
Okay, well, welcome everybody. And Greg and Kavita, thank you so much for asking me to speak today. And thank you to ANMS as well. Very excited to be here and really excited to kind of talk about a topic that's near and dear to my heart. And what I hope to do over the next 20 minutes is really give you kind of my perspective on the evidence for what we do in IBS. And we're going to start, just bear with me for 1 sec. We'll start here. And our objective really is to look at current therapies for the treatment of IBS using the best evidence from the literature. And I'm going to break this up into two sections. The first is to focus on evidence-based therapies for IBS with diarrhea, and then we'll spend some time looking at evidence-based therapies for IBS with constipation. And at least when I see a patient in clinic and use the evidence, what I'm really excited about these days is when we look at this list here, medical treatments for IBS with diarrhea, we have a host of therapies now available. And our job as clinicians is to really think about our patients and try to categorize them. Do they have mild symptoms, moderate symptoms, more severe symptoms? Is there a lot of ongoing psychological distress? What's their level of education? What's their level of risk-taking behavior? And possibly also what have they tried before? And what might their insurance company allow them to try? So it's kind of a long discussion. And now let's kind of look at the data and try to go through all these different possibilities that may help improve your patients' lives. So unless you've been on a desert island for 10 years without radio or the internet, you've heard a lot of information about dietary therapies for IBS. And this slide here lists 10 different common therapies employed by patients. But when we drill down, let's really look at the data about diets that may improve your patient's symptoms. And obviously, the most commonly used diet for IBS patients is the low FODMAP diet, excluding diets that are high in fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. There have been, and it makes physiologic sense, as all of you know, because these agents, which have a high osmotic load, promote accelerated movement throughout the GI tract. And when they reach the colon, cause a lot of fermenting, gas, bloating, distension, discomfort. 13 trials to date involving over 900 patients. And what was shown in this very nice meta-analysis by Chris Black with Alex Ford is that the low FODMAP diet was certainly better than all other diets where we had available evidence, and certainly better than the dietary advice provided by the British Dietetic Association, which includes the National Institute for Clinical Health and Excellence. So certainly if you're going to recommend a diet based on data, I would recommend a low FODMAP diet at present. That said, there was a really interesting article published in late 2023. The senior author is Magnus Simran from Sweden, who's done so much for the field of IBS. And this was a single center, single blind, randomized controlled study looking at all patients with IBS. So not just IBS-D, but all subtypes. They had to have moderate symptoms. And there were 3 arms to the trial. And the trial was 4 weeks in duration, and patients were randomized. And what they were looking for was a 50-point reduction. The 3 arms were a low FODMAP diet combined with traditional dietary advice. And in Europe, that dietary advice is kind of common sense. Less alcohol, less caffeine, less foods that irritate you. Avoid sugar-free candies, gums, and mints. Take your time, eat smaller meals. And that was compared to a low carbohydrate diet. Don't forget the concept there is fewer carbs, including sucrose, means that you will likely have less fermentation, less gas and bloating, or what was considered medical management appropriate to that patient. And that could include any number of agents for IBS-D or IBS-C or IBS mixed. Most of these patients were women, they were younger patients, and what's shown on this slide here is that both diets, the low FODMAP diet and traditional dietary advice in red, or the low carbohydrate diet, were better during this 4-week trial than what was considered optimal medical therapy. So this is really interesting. By the way, the patients were encouraged to continue the diet for 6 months, and there were still continued gains. So common sense dietary advice in the low FODMAP diet seems to make sense. What about a low gluten diet? I like to still show this cartoon here published years ago, and what it says, if you can't read it, is I've only been gluten-free for a week, but I'm already really annoying. And that's true. This is a hard diet to follow. But when we look at the data, there's very little data. In fact, there were only 2 trials. One was probably carried considerable risk of bias. Total number of 111 patients showing that a low gluten diet did seem to improve some symptoms. But we've learned since then it's probably not the wheat and the gluten, it's fructan in these wheat products. So have your patients avoid fructan, have them avoid high fructose corn syrup, and they'll do just as well. So I don't recommend this diet. What about peppermint oil? That was number 2 on the list. A lot of patients like to use peppermint oil. We have data from the literature involving 12 randomized controlled trials involving nearly 900 patients showing that peppermint oil is likely to improve global IBS symptoms. This was given a conditional recommendation by the ACG. Quality evidence is lower on the lower side. That said, a reasonable number of patients in a large number of trials. Safe, easy, efficient, with few side effects. What about probiotics? Patients love to take probiotics, and many providers like to recommend probiotics. If we really ask, though, how do they work? The real answer is we don't really know how they work in IBS patients, and likely they work differently in different IBS patients. And I've provided a number of different possibilities here about how probiotics work. Remember that many, if not most, have never been tested in clinical trials, and a lot of these probiotics are dead on arrival and may not help. If we look at a wonderful meta-analysis involving 82 studies with over 10,000 patients and employ the grade recommendations, what was found is that only 24 trials were at low risk of bias. That's only 24 out of the 82. And if we look at improvement in global IBS symptoms, Escherichia and Lactobacillus provided some benefits for global IBS symptoms. Recognizing that for abdominal pain, the cardinal symptom of IBS, really there was no good probiotic. The quality of evidence was very low. And for bloating, the quality of evidence was even lower. So I personally don't recommend probiotics for bloating because it frequently makes things worse. What about anti-diarrheal agents for your patient with IBS-D? Loperamide is available. We know that's been around for about 40 years. That said, there's very little data to support its use, and importantly, it doesn't treat the cardinal symptom of IBS, abdominal pain, so I don't recommend that. And I don't recommend diphenoxylate atropine because not just the limited amount of data, but because of the potential side effects. What about antispasmodics? This is actually a controversial area. There have been 23 randomized controlled trials involving 12 different antispasmodics, a total of over 2,000 patients in our review. But there was significant heterogeneity among the studies. We know that in the United States, we only have a few options. However, there are many more options in South America and in Europe. And in South America and Europe, these agents are widely recommended. If you look at this careful meta-analysis, using antispasmodics did lead to a better improvement in symptoms than placebo, excuse me. That said, these medications are frequently associated with side effects, and as many listeners know, in the United States, only one trial, dicyclamine, performed nearly 40 years ago, and 60% of patients had side effects. I tend to recommend this more for intermittent or PRN use rather than chronic use. What about bile acids for the treatment of and bile acids and the role for IBS-D patients? So we know that in IBS-D patients, about 20 to 30% of patients may have a bile acid component. We know that bile acids stimulate movement through the GI tract. They increase visceral hypersensitivity. They're associated with abdominal pain. In Europe, you can diagnose this with a CCAT test. Here, we use a serum C4 as a surrogate marker. We don't have any good randomized controlled trials for the use of bile acid sequestrants in IBS with diarrhea. However, cholestyramine, cholesevelam, and cholestyramine make clinical sense, and certainly a good 4 to 6 week trial is reasonable if you suspect that bile salts are playing a role. What about the use of 5-HT3 antagonists? And let me start with ondansetron. This is data from a study published nearly 10 years ago now. In this crossover study showing that ondansetron in patients with IBS and diarrhea by the Rome-3 criteria had an improvement in symptoms of diarrhea and some improvements in urgency and bloating. However, it did not help abdominal pain, and that's important. So this study was really interesting, well cited, and it led to a lot of providers using ondansetron to treat IBS with these symptoms. This led to a larger proposed study called the Triton study, which is going to be a phase 3 double-blind randomized controlled study in Europe, looking at ideally 400 patients for a 12-week study, comparing ondansetron at 4 milligrams or placebo. The problem was they had great difficulty enrolling an adequate number of patients, and the study was stopped prematurely with just 80 patients. Again, the results were that diarrhea symptoms improved to some degree, stool consistency improved to some degree, but it didn't help abdominal pain. And again, that's the number one reason your patient with IBS comes to see you. Another 5-HT3 antagonist is elocitron. Some providers may have kind of put this on the back burner because of some concerns about safety, but we have very good data from many large randomized controlled trials showing that elocitron, a 5-HT3 antagonist, improves global IBS-D symptoms, including abdominal pain, urgency, diarrhea, and even incontinence. This was a really neat study published late last year in Lancet by Alex Ford and colleagues, and this is called the Atlantis study, focusing on amitriptyline for IBS, and this includes all IBS subtypes. This is a randomized, double-blind, placebo-controlled study performed in primary care practices in Europe. And the patients enrolled met Rome 4 criteria and all had failed dietary interventions and simple over-the-counter therapies. So this data would apply to many of us on the call tonight. Amitriptyline was compared to placebo, and over a few-week period, patients were upregulated or uptitrated from 10 to 20 to 30 milligrams of amitriptyline compared to placebo, and this study lasted 6 months. What were the results? Well, the results shown here on the right is that this low dose of amitriptyline in all IBS subtypes at typical doses were 20 to 30 milligrams were more likely to improve global IBS symptoms than placebo. And the vast majority of patients also reported using other questionnaires kind of a greater improvement in quality of life as well. So be confident using low dose neuromodulators such as amitriptyline to improve global IBS symptoms. And contrary to what many people believe, low dose typically does not worsen constipation. That IBS-D patient who may have failed dietary interventions, what about using a non-absorbable gut antibiotic such as rifaximin? This is the NICE data from Mark Pimentel published 13 years ago in the New England Journal of Medicine, showing that rifaximin, shown here in red, was much more likely to improve global IBS-D symptoms than placebo, and also individually improve symptoms of pain and bloating. Many of us use this routinely. It's very safe. Is it effective for a second and third dose? The answer is absolutely, and this is from a large randomized study performed by Tony Lembo and colleagues, showing that patients who received a second or even a third dose of rifaximin had persistent improvement in symptoms, and this is much better than placebo. So rifaximin shown here in red with persistent improvement in symptoms compared to placebo. What about eluxadiline? So eluxadiline works differently than the other medications we've talked about. This is a mixed mu opioid receptor agonist, delta receptor antagonist. The concept here is that by acting on the opioid receptors in this mixed action, it can improve pain and can improve diarrhea symptoms, but not make you overly constipated. So good physiologic sense here. This study was published in the New England Journal of Medicine in 2016, showing that eluxadiline at either 75 milligrams twice a day or 100 milligrams twice a day, shown in the light blue or dark blue, was much more likely to improve global IBS-D symptoms than placebo, shown here in gray. There is some concern about possible side effects, and the bottom line here is if you have somebody with IBS-D who has failed diet and standard therapy, this is a reasonable and over-the-counter therapy. This is a reasonable choice, but don't give it to somebody with a known history of alcohol use or alcohol abuse. And alcohol abuse in this case would be more than 3 drinks per day, or those with a prior cholecystectomy or known sphincter of Oddi dysfunction. What about using gut-directed psychotherapies? And the teaching point here is these gut-directed psychotherapies, such as cognitive behavioral therapy and hypnotherapy, can be very helpful for IBS symptoms. That includes both IBS-D and IBS-C. The number needed to treat is 4, much lower than many medications. And you don't need to save this as a last-ditch effort. So for your patients where you can get gut-directed behavioral therapies such as CBT or hypnotherapy. This, in combination with some simple medications and dietary therapy, may be all you need. So don't save it for last-ditch effort. If we look at a comparison of ACG guidelines on the left and AGA, American Gastroenterological Association, on the right here, they're actually pretty similar in terms of the medications I've just discussed, except that the ACG did not recommend antispasmodics because they didn't seem to improve global IBS symptoms. AGA guidelines were written a little bit differently, but they did recommend antispasmodics. All right, let's shift gears for the next few minutes and talk about medical treatments for IBS with constipation. And this is the list of treatment options currently available. And I'd like to start with over-the-counter therapies. Fiber makes physiologic sense, right? It adds bulk to the stool, it helps accelerate transit, and can certainly improve constipation symptoms. But don't forget that many fiber products worsen bloating, so that may cause some distress in some patients. Osmotic agents, and I'll focus here on polyethylene glycol, improve symptoms of constipation, but it's been shown in 2 studies not to improve symptoms of abdominal pain. So I generally do not recommend that for my IBS with constipation patient. So that leaves us with 5 FDA approved medications for the treatment of IBS with constipation. I think most of the listeners are very comfortable with this. One of the first approved is lubiprostone. Lubiprostone is a chloride channel antagonist. It helps block the chloride channel, excuse me, it's a chloride channel agonist. It stimulates movement through the GI tract. It holds onto water within the GI tract, which stimulates peristalsis. This was approved in 2008, but keep in mind that it's technically only approved for women with IBS and constipation. It does work in men, but the studies were not powered to include men. What about the 2 other secretagogues, which we'll refer to as GCC, guanylate cyclase C agonists, either linaclotide, which is 14 amino acids, or plecanatide, 16 amino acids. Both of these, by acting on the GCC receptor, help again stimulate movement through the GI tract and help with visceral pain. We have good data from the last 12 years for linaclotide and for the last 6 years on plecanatide. No head-to-head comparisons, but these are very efficacious and safe. Tenapanor is kind of the new kid on the block. I'll mention this again in a second. And this works differently. It's a sodium hydrogen exchanger isoform 3. It blocks the absorption of sodium from the GI tract. By doing so, it once again kind of stimulates movement through this osmotic load and improves visceral pain. Tegasterod is listed here because it is FDA approved, but for commercial reasons, it's no longer available, so we won't discuss that more. This slide here kind of shows the mechanism of action of these drugs, from tenapanor on the left to lubiprostone acting on the chloride channels to the GCC agonist linaclotide and plecanatide on the right. I'll just mention tenapanor again because it's kind of the new kid on the block, and some listeners have not heard about this before. Again, it acts on a sodium hydrogen isoform exchanger 3. It blocks sodium absorption. And this is data from a 26-week study involving over 600 patients, showing that global symptoms of abdominal pain and constipation improved, as did individual symptoms of pain or CSBM, complete spontaneous bowel movements. If we look at a comparison of the ACG recommendations to AGA, we'll find that once again, they're pretty similar. I mentioned antispasmodics, a slight difference there. When the ACG guidelines were published in 2021, we did not have all the data for tenapanor, so we didn't discuss this. However, the AGA did give it a conditional recommendation based on moderate quality of evidence, so you should feel comfortable using that agent. Lastly, what about augmentation therapy? We do this for other disorders. Feel comfortable doing augmentation therapy for your patient. What does that really mean? It really means just combination therapy. And you can use this when the therapeutic effect from one agent is not sufficient, or maybe you're getting side effects at a higher dose, so you need to cut back, and then you may want to add in another dose. And all types of combinations could be used, all types of augmentation therapy. Think about adding cognitive behavioral therapy to a tricyclic, or adding buspirone to SNRI therapy like duloxetine, or you could add a low-dose neuromodulator such as a tricyclic to an SNRI, or even diet and a tricyclic, right? Lots of different possibilities. Feel comfortable using these combinations. So in summary, we didn't talk about the epidemiology, but we know IBS is quite prevalent. It has a huge impact on quality of life. What's great news now is we have a lot of different treatment options for your IBS-D patient, and nearly as many for your IBS with constipation patient. Remember, the data on probiotics is pretty weak. Definitely consider low-dose tricyclics low-dose neuromodulators, because we now have great data from Alex Ford and colleagues, and don't forget to use augmentation therapy. I'll stop there and happy to listen to Dr. Shin, and we'll have questions at the end. Thank you so much.
Thank you so much for that great presentation, Dr. Lacy. And now I'd like to introduce Dr. Shin. She specializes in the care of patients with disorders of gut-brain interactions, DGBIs. Those of you that are listening right now, this may be a new term for you. You will hear more about this. And GI motility disorders. She's committed to providing individualized care that emphasizes multidimensional nature of DGBIs and motility disorders, and her research and clinical expertise focuses on developing novel diagnostic and therapeutic approaches to treating patients with conditions such as IBS, functional diarrhea, chronic constipation, and anorectal disorders. So with that, I want to thank Dr. Shin for being here, and we look forward to hearing your presentation.
Well, thank you for inviting me. Hopefully my slides are showing up well. So I am going to kind of move on to the next section of today's session, do the IBS guidelines stand up in clinical practice. And I think Dr. Lacy really set me up very nicely for this. So objectives over the next 20 minutes, I'll just provide a high-level summary of some of the content that Dr. Lacy just reviewed for us, which is management of IBS according to National Society guidelines, and I'll also provide just a brief summary of the diagnostic evaluation. But the focus of the next 20 minutes will be to describe, so what have we learned from clinical practice? What is the real world evidence for the efficacy of these guideline-based approaches, including dietary treatments and pharmacological treatments? And so I'll focus on those two components. And then another aspect that I think might be interesting for us to discuss is the possible impact that these guidelines could have on healthcare use and spending in patients with IBS. And then we'll finish up by examining patient perspectives and experiences in the era of guideline-based care for IBS. So as you can see here, I just kind of showed a little visual. We're really fortunate now that we do have strong National Society guidelines that offer us a rational framework for the approach to diagnosis and testing in patients with IBS. Two of the main resources, and Dr. Lacy mentioned this in his talk, are guidelines from the AGA and the ACG. And although there are some specific details within each guideline that can exhibit slight variations, the general approach is consistent. And ultimately, the diagnosis of IBS can be made based on detailed clinical history and a limited repertoire of tests, which we can determine according to patient-specific features and risk factors. And concomitantly, we have now these evidence-based recommendations for management of IBS, and this has really been supported by the rise in the number of clinical trials for IBS therapies and the expansion of pharmacological agents that Dr. Lacy covered for us. The general approach to management, according to these guidelines, usually advocates for first-line steps, which include things like education, reassurance, lifestyle modification. And then following this, we'll apply tailored and targeted treatments, which can include dietary treatments, pharmacological agents, and mind-body-based interventions, such as cognitive behavioral therapy, or maybe even gut-directed hypnotherapy. So now the question is, we have these guidelines available to us now. How have they impacted clinical practice? And we can start maybe by looking at the data on the effect that dietary treatments have had on outcomes in patients with IBS. So it's widely recognized that the majority of patients with IBS relates some symptoms to food ingestion. And our society guidelines do recommend diet modifications, which among the most well-known is the low FODMAP diet, as Dr. Lacy covered, as an early step in IBS treatment. Use of dietary modification, however, should also be accompanied by careful understanding of a patient's preferences and their goals, as well as being able to identify possible risk factors for nutritional adequacy or disordered eating. So The low FODMAP diet is a restricted diet. It is intended to be short in duration, and it is to be followed by careful reintroduction and personalization. And so I think it's interesting to see if there's data on examining how well are we actually doing this in practice. How well is the low FODMAP diet performing in the long term? Are there any possible effects on nutritional quality or even other outcomes that are still evolving, such as the microbiome? Recently, Heidi Staudacher and colleagues a couple of years ago, they actually published this study looking at the long-term effects of the low FODMAP diet. This was a prospective study, and it was fairly small. It involved 18 patients, but they were followed over 12 months. And at the end of the follow-up period, it was observed that reintroduction and personalization with the low FODMAP diet was associated with an improvement in IBS symptom severity scores, overall in GI specific symptoms, as well as improvements in quality of life. And there was adequate relief achieved in 28% of patients. They also assessed outcomes related to microbiome composition, and they showed that the abundance of bifidobacteria was maintained. However, they did notice changes in the relative abundance of some other bacterial taxa and stool short chain fatty acids, as well as changes in intakes of dietary components like total energy and macronutrients, including carbohydrates, protein, and fat. It is important to note that this study was actually conducted as a follow-up of a larger RCT, and only 25% of patients in the original RCT actually participated in this long-term trial. So I think the main findings from this study is that from a long-term perspective, it seems that the low FODMAP diet is durable, and it's effective, and it's relatively safe, but we do need more data on the feasibility and other possible effects on patients moving forward. Caroline Tuck and colleagues also published a paper describing their real-world experience with the low FODMAP diet in a case series of patients with disorders of gut-brain interaction. And they demonstrated that most individuals were able to follow this initial restriction phase, but a much smaller proportion of patients actually followed through with appropriate reintroduction and maintenance. When they looked at adherence rates in patients who had seen a dietitian, adherence rates were higher, and most patients did report at least a 50% improvement in symptoms. And interestingly, the response rate didn't actually differ between those who met with a dietitian or those who didn't. About half of patients reported at least a 50% improvement, but the other thing to note here was that the patient preferences seem to have a large effect. So patients who expressed a preference for dietary treatments were more likely to respond. And so here, additionally, the low FODMAP diet, it was noted that even though it is recommended as a first-line strategy, the vast majority of patients in this cohort were also using other forms of therapy at the same time, such as medications. So with this information in mind, recently there have been alternative approaches such as a FODMAP simple or a bottom-up approach, where patients are advised to restrict only a few specific subgroups according to their symptoms or according to commonly observed food triggers. And this approach might be particularly helpful for patients with milder symptoms or patients who theoretically could be at higher risk of nutritional inadequacy or disordered eating. So I think that will be really interesting to see how this plays out in clinical practice as well. Let's move on to how guideline-oriented care has translated into clinical practice when it comes to pharmacological agents. So although we don't have time to cover all treatments, I wanted to cover a few. Okay. So this is a nice paper, actually. Dr. Lacy is the first author, but I came across it and I thought it was really relevant for today's talk. So rifaximin and elaxadiline, these are two FDA-approved treatments for the treatment of IBS-D, and both are commonly used as prescriptions in patients with IBS-D. And here, the investigators recognize there's a need to examine the clinical and economic impact of these agents in a real-world setting. So for this study, the authors conducted a retrospective analysis of administrative claims data, and they examined all-cause healthcare costs and treatment-free intervals, which was defined as a period of at least 30 consecutive days without the need for IBS-D treatment. And the results of this analysis demonstrated higher rates of treatment-free intervals in patients who were treated with rifaximin, as well as lower all-cause healthcare costs. And I think these findings are really consistent with the guideline recommendations, which do recommend both agents, but actually offer a stronger recommendation for the use of rifaximin. How about IBS-C drugs? How well do these play out in clinical practice? A few years ago, a group of investigators examined data from the chronic constipation and IBS-C treatment and outcomes real world research platform, or CONTOUR. And their goal was to assess patient perceptions on treatment effects. So for this study, the authors examined the relationship between stool form and treatment satisfaction. And they found that people who experienced loose stools or normal stools expressed higher rates of satisfaction than those who were experiencing hard stools. They also looked at medication usage to find that people who used linaclotide or linaclotide with another medication reported greater proportions of bowel movements that were characterized as loose or watery, and rates of satisfactory bowel movements were generally highest in those treated with linaclotide. They also noticed that rates of satisfaction differed across the different stool types, but in general, they were highest with linaclotide regardless of the stool type. Another important point here that the authors mentioned in their paper as well is that it's interesting to note that loose or watery stools was often selected as a satisfactory outcome for patients, even though it is commonly documented as an adverse event in clinical trials. And this information, I think, helps to underscore the importance of discussing patient goals and perceptions with regards to clinical outcomes, including stool consistency, and could be helpful in guiding us on effectively utilizing IBS treatments in the clinic. Another study, this was published by Eric Shaw and colleagues. This study examined rates and reasons for treatment discontinuation in patients with IBS-C and patients with chronic idiopathic constipation. In this study, the authors conducted a retrospective analysis of the electronic medical record, and they used Cox proportional hazard models to predict medication discontinuation. So these figures here demonstrate the adjusted risk of discontinuing therapy stratified by reason for discontinuation. So the reason could be any reason, intolerance, or lack of efficacy. And they observed that individuals were more likely to discontinue lubiprostone for any reason or due to insufficient efficacy. And in contrast, they were more likely to discontinue linaclotide due to intolerance. Again, this is important data, really highlights the experience of these agents in clinical practice, and again, could be helpful in guiding conversations between patients and providers with respect to long-term goals or perhaps expectations. TCAs, I'll be very brief on this. Dr. Lacy covered this in his talk as well. There's really limited observational data reporting real-world efficacy of neuromodulators in IBS, but this paper, the results of this large double-blind RCT, I think really emphasized the efficacy of amitriptyline because this was studied as a second-line treatment in primary care patients. Like Dr. Lacy mentioned, amitriptyline was superior to placebo for primary and key secondary outcomes, and there were no differences in things like symptom reporting or anxiety or depression or work or social adjustment scores. So I wanted to include this as well because the guidelines do support the use of neuromodulators, including particular TCAs for the treatment of IBS. And I think this study really verifies that approach is sound and also actually strengthens the level of evidence supporting those recommendations. How about brain-gut behavior therapies? These are also included and incorporated into the IBS guidelines. This is data from a recent study by Kyle Stoller's group, where the authors demonstrate the potential real-world efficacy of digitally delivered cognitive behavioral therapy. So in this study, the research team analyzed real-world user data from 843 patients who were using the Mahana IBS app. They observed that about 38% of the participants completed all 5 sessions and only 19% completed all 10. but participation or use of this app did lead to significant improvements in IBS symptom severity scores. And among completers, almost half achieved a 50-point improvement by session 5, and 59%, so almost 60%, achieved that 50-point improvement by session 10. So I think this study really provides some great practical data to support the role of CBT in IBS management, although obviously we need to develop some efforts to find out ways to better increase adherence and retention in these programs. Another important note that I'd like to explore is the potential impact that these guidelines might have from an economic and healthcare system perspective. So it's widely recognized healthcare costs and resource utilization in IBS are substantial, and older studies estimated IBS-associated healthcare costs in the United States to range from about $1,500 to $7,500 per year in terms of direct care costs. And it may be informative, I think, for us to understand how have the availability of these evidence-based guidelines, if they've had any yet, led to any sort of measurable changes in utilization and spending, and perhaps on patient experiences and perspectives. So our group recently conducted a retrospective analysis of de-identified claims data in order to estimate healthcare utilization rates and costs, and we included all-cause and IBS-specific costs. And what we found was that comparisons of annual healthcare utilization rates and costs between patients with IBS and non-IBS controls within the time period of 2016 to 2021, we found that there were higher total costs, higher rates of healthcare use, and higher costs for all individual services in patients with IBS. Interestingly, when we looked at the cost breakdown, however, IBS-specific spending was only estimated to be about $1,100 per year. Highest costs were observed in the IBS-C subgroup, who incurred a median total all-cause cost of about $16,000 and IBS-specific costs of about $2,000 per year. So two important takeaways here are that healthcare costs in patients with IBS may actually be growing because these estimates are much higher in terms of overall spending compared to previously published estimates. But when we looked at the cost breakdown, there is data here suggesting that a large component of the costs are not actually attributed to IBS-related claims. A nice correlate to this study may include these findings that were actually published a few years ago. This was a paper that sought to estimate IBS-specific costs using a microsimulation model. The model was designed to track cumulative costs of a patient with IBS as they moved through all possible single-agent treatments over 1 year. And this was from Eric Shaw and colleagues. And the basic model here is shown on the left. It was assumed that patients would discontinue therapy if they didn't tolerate it, and then would begin the next treatment in the algorithm. And in this model, patients could either respond or not respond to treatment. And they also accounted for possibility of adverse effects. And they input the estimates based on data from recent systematic reviews. So results of the main results of the analyses demonstrated that patients with IBS-D incurred about $2,000 in healthcare costs, and patients with IBS-C incurred almost $4,000 over the course of the year if their IBS was not treated. But in the model, when patients were routinely using global IBS treatments, and this could have included central neuromodulators, low FODMAP diet, cognitive behavioral therapy, and if they use these global treatments before drug therapies, this would then lead to a cost savings of about 9,000 patients for IBS-D and about 3,000 for IBS-C. Health outcomes were similar regardless of the sequence of treatments, and they also looked at cost effectiveness. And in IBS-D, the most cost-effective algorithm was rifaximin, followed by eloxatiline, followed by olocatron. In IBS-C, the most cost-effective algorithm was linaclotide, then followed by either plecanatide or lubiprostone. And of course, this was published a couple of years ago, so tenapanor wasn't included. But again, I think this study demonstrates that general treatment approaches followed by drug therapies as recommended by our current guidelines are cost effective, And again, might even suggest, we really can use central neuromodulators and brain gut behavior therapies earlier in our algorithm. We don't necessarily have to wait until patients are struggling with very severe symptoms. The last point I want to touch on is how these evidence-based approaches have been received from the patient perspective. In addition to their impact on the healthcare system, IBS is associated with reduced quality of life, decreased daily functioning, and negative emotional and psychosocial effects. So there was a survey conducted by the HEA in 2015 of over 3,000 patients. And in this study, it was also observed that patients with IBS really struggled with decreased productivity. And on average, they reported that their symptoms interfered with work or school 9 days per month, or caused them to miss work or school 2 days per month on average. A few years ago, Tony Lembo's group then utilized the survey data to analyze treatment usage in patients with IBS. They found that GIs were more likely to prescribe specific agents like bile acid sequestrants or rifaximin for IBS-D, as well as agents like linaclotide and lubiprostone for IBS-C when compared to primary care providers. And this may be due to increase in comfort experience with these IBS-specific treatments or with the IBS guidelines. From the patient perspective, approximately 25% of patients who were treated with FDA-approved prescriptions reported actually being very satisfied. And this is higher than the proportion of patients who reported being very satisfied with non-prescription agents. So, but, I think one observation to make here is that while the availability of IBS-specific treatments is associated with higher rates of satisfaction, there are still relatively high levels of dissatisfaction or just feeling somewhat satisfied in a large number of patients. And there actually at the time of this survey, there are a lot of patients who reported never having tried FDA approved prescriptions for IBS as well, suggesting that perhaps IBS medications could be underutilized. So in summary, we're in an era right now where diagnostic evaluation and management of IBS can be well guided by evidence-based guidelines. We can make a positive diagnosis of IBS based on history and limited testing, and the main components of management include dietary approaches, medications, and even behavioral therapies. We treat according to symptoms while also taking into account patient preferences and goals, but we do still acknowledge there's still work to do. The rates of dissatisfaction may still be relatively high among some individuals. The other important point is that there do appear to be other factors beyond IBS symptoms alone that uniquely impact quality of life or even healthcare spending among patients with IBS. And now, our available guidelines really, I think, offer a strong framework for us to help work on improving health outcomes and reducing costs compared to, a lack of these guidelines or no treatment. And then moving forward, studies of success rates in clinical practice, long-term outcomes, the impact of non-IBS related factors on healthcare use and spending will probably be very helpful.
Great. Thank you so much, Andrea, for that outstanding discussion. We do have time for some questions as anticipated. And I would encourage the audience to type those questions into the Q&A. We've had several questions already posted. So Brian, I'd like to start with you. You reviewed nicely multiple studies that have been conducted in the treatment of IBS. And of course, many of these studies use a variety of endpoints. From the combined response endpoint more recently per regulatory guidance, and some older studies that use adequate relief or even global symptoms. Can you comment on the impact that those endpoints might have in the outcomes of these trials and the interpretation in comparing, say, one treatment to another?
Wow, what a great question. And the answer is, yeah, it likely does change how we think about things. Think about how this whole field, for the person who asked the question, how this whole field has evolved in the last 20 years and even in the last decade, meaning we used to simply ask, do you feel better? Kind of symptom global assessment of relief. Do your IBS symptoms feel better? yes or no, or a 3-point ordinal scale or something. And all the trials were basically 4 weeks in duration, right? It's much smaller trials. And now the FDA is recommending longer studies, so they should be a minimum of 12 weeks. And we know that symptoms kind of wax and wane a little bit, and people can kind of regress to the mean. So longer studies probably are better, but they're very expensive to do. And it's not really fair to compare a 12-week trial to a 4-week study. In addition, now the FDA is, as this smart person asked and is aware, we're now using these endpoints of a reduction in pain and improvement in bowel habits. And the reduction in pain is kind of an arbitrary thing. There's not a lot of great data why they said a 30% reduction, right? That's just kind of made up by the FDA, to be honest. So we have to be very careful how to interpret it. What would we like to do ideally? We'd love to see 26-week data, and we do have some 26-week data from linaclotide, and I mentioned tenapanor and some other agents, and even eloxatiline. We do have long studies. We'd love to be comparing them all with the same global endpoints. And there's actually a little bit of a shift now in some European studies. You saw that with the Atlantis study. Andrea, thank you again for highlighting that we're asking, what about just global assessment of response? How do the subjects globally feel about their symptoms? And maybe that is the best thing. Time will tell. Kind of the field is still continuing to evolve and morph.
Great, thank you.
I see a question here. And this can go to either Dr. Lacy or Dr. Shin, what alternative regimens you specifically think about for methane predominant SIBO if rifaximin or neomycin are cost prohibitive? I think they're addressing, we touched on, the multifactorial nature of IBS, but I think they're specifically asking about SIBO. I don't know if you have some easy one to answer, but a quick thought on that, either of you?
I'll put my foot in my mouth first. So what a great question. And if you're willing to stay on the line for another hour, we can answer this. This is incredibly controversial, right? We could start by saying, what is SIBO and what is intestinal methanogen overgrowth? And I think a lot of smart people really debate what is it. But let's assume we all accept the same definition, too many methane producing bacteria. We know that methane slows the GI tract, and we know that methane can cause symptoms then of constipation and certainly be part of IBS, either the primary component of IBS or, it's a comorbid condition. And if a non-absorbable antibiotic like rifaximin doesn't work, or the combination, which may be better, what to do? Well, this is now in the data-free zone. We are in a data-free zone now. And do you use other antibiotics, knowing there's some risks? We don't have really any data. There's some neat data from Mark Pimentel, who's been such a really amazing pioneer in this field, that maybe we should even use a cholesterol lowering drug, and that might be beneficial, but those results have not been published. So I think more to come. I think it's fascinating. We're learning a lot about physiology, and I think it shows how little we really know.
Great, thanks, Brian. Andrea, did you have anything you would want to add to that?
No, I think, Dr. Lacy did a really good job of basically emphasizing the challenge of, determining a diagnosis as methane positive SIBO as an entity that we can specifically target or treat. And so I think there are just a lot of questions out there. So I don't have a specific direct answer in terms of next step in treatment or management or antibiotic algorithm. I think for each patient, the approach is probably different depending on what their predominant symptoms are.
Yeah, you emphasized that nicely, the fact that it's obviously not one size fits all management for patients. And we, of course, have evidence for a lot of different therapies, but patient preference certainly comes into the equation early in the discussion as well. So a question for you is how do you prioritize those two facets of management decisions with your IBS patients? What does that conversation look like with your IBS patient when you see them in clinic?
So I usually explain to them that we have kind of an integrative model in terms of how we approach IBS, and I acknowledge that we have prescription agents, medications, that we have dietary treatments, and that we do have body-based or body-based treatments. And I actually just ask them, are there certain elements of this treatment program that are more attractive to you? And what do you want to try first? I have a lot of patients who actually say they're really interested in diet and they are interested in learning more about cognitive behavioral therapy. I think that there is growing acceptance and acknowledgement, especially with all the evidence that has been published. And so I take that into account. And then I let that guide like the sequence of treatments.
Great. And I'm just going to come back with one other question for you. There was a question that was asked about any thoughts or practical points you might have in trying to get insurance coverage for some of the newer IBS therapies that are expensive. Any practical tips there?
You know, I can start. We are fortunate here. We generally don't have a lot of problems, but I think we're just fortunate here. I always try to point out on the prescription what patients have failed before. So as an example, whether it's linaclotide as an example, or plecanatide or tenapanor, I will say patient has failed fiber, Miralax, lactulose, and then the other agents that they may have failed, prescription agents, to try to push that to the top. And oftentimes that seems to be successful. Similarly, for something like rifaximin, I try to highlight what they failed before, and I point out, you know, it is FDA approved for the treatment of IBS diarrhea as an example, and sometimes stating that will help your case.
Yeah, I think that's a great point. I would echo the same that documentation is really a key that I found can be helpful for patients. You know, once the record of what they've previously tried and failed is documented, that may help. Um, Brian, I know that you, of course, are well recognized as an international authority in the management of IBS, and so you undoubtedly see, you know, the most challenging of patients, and oftentimes these are the patients that end up more likely to be enrolled, perhaps in clinical trials. So the question for you is, you know, how does the data that we derive from clinical trials with these different therapies translate to the average IBS patient, the patient that we, you know, perhaps are seeing in the community as opposed to in an academic or tertiary practice?
Yeah, great question. So, you know, when you think about community practice, oftentimes there are patients with more mild symptoms, but not all the time. And I see a few of those too. So I think about those mild patients, you know, it's not causing a lot of psychological distress. They're not missing work. They're not missing school. As Andrea pointed out, you know, many of these patients do very well with diet and over-the-counter agents or diet and some other form of therapy, even including behavioral therapy. However, whether in the community or in academic practice and for clinical trials, you know, if they failed diet, they failed OTC therapy, maybe they failed one or two other things, then those are the patients that many of us all, either on the call or I can see on the screen tonight, see those same patients. And this is again where you dig into it. What's your most bothersome symptom? What are you worried about? How can I reassure you? Let's make sure you had adequate trials before of other agents. You know, a 3-day trial is not adequate, and whether options have exist out there, including augmentation therapy.
Great, thanks. And Dr. Shin, I think we have time for maybe one more question. There was some interest in the by the audience in any tips that you might have with regard to use of neuromodulators, selection of an agent, you know, kind of strategy that you employ there. And that's obviously a very broad question, but maybe you could offer, you know, one or two tips or resources that you might refer an interested individual to learn more about neuromodulators.
I use neuromodulators pretty frequently, but that's also probably a reflection of, you know, the patient panel that I see. But I do use TCAs and SNRIs quite often. And then I also try to take into account what their predominant symptoms are. So if they do have pretty debilitating, you know, constipation or, IBS-C, and I don't necessarily want to potentially exacerbate that, I might be more likely to use an SNRI. Or for example, if they've got a strong component of coexisting anxiety, I may be more likely to use an SNRI because it can treat anxiety as well. But TCAs actually have such great evidence, and I found them to be very successful for symptoms such as pain. So if you have a strong pain component, going to a TCA, I think, is really helpful, even in patients who do have constipation, particularly if it's mild. And you just might want to select a TCA like nortriptyline or disipramine, something with less cholinergic side effects, but they can be used in constipation as well. You don't have to just avoid them strictly.
Perfect. Well, I think we're going to, with this, conclude our program. I want to thank both of our outstanding speakers, Dr. Lacy and Dr. Shin, as well as our audience participants in this evening's program. If there were any questions in the Q&A that we did not specifically get to, we'll try to post some responses to those in our ANMS Doc Matter web forum. Lastly, I want to make a couple of announcements. First, if you're not an ANMS member, I encourage you to join our community. We're the American Society home for neurogastroenterology and motility. And as a final reminder, it's not too late to register for our 2024 ANMS clinical course entitled New Approaches and Best Practices in Complex Patient Care. This will be held July 26th through 28th at the Marriott Baltimore waterfront. So with that, I will conclude this evening's virtual ANMS Clinical Symposium. Thank you again to our speakers in the audience, and everybody have a great night.